microphones muted unless you're going to talk. And as you've noticed, we record these meetings so that we can refer back to them, but also for people who have not been able to join us. I will try to keep admitting more people as they join. They show up in a meeting room, but I think Phoebe, you can also help to bring some people on if they are in the waiting room. So yes, this is the Africa Cancer Control Echo. We meet every month and discuss issues concerning cancer control, the whole spectrum, prevention, treatment, research, health system strengthening. And today's topic is about financing, which I think is quite timely, given the whole events that are happening in Kenya. Some of them have been very unfortunate, but there's also seeming to be interesting turn. So I guess kudos to you, the colleagues in Kenya, and let's hope that things go in the way that everyone wishes they would in terms of financing. Today we do have, as usual, two interesting speakers. So something that is more, let's say, theoretical or academic, and then the other will give us a case presentation, an example of what's happening in the field. So again, welcome everyone. We will request you that you have your cameras on. That helps the speaker to know if you are lost or if you are appreciating what they're saying, or if you need, just to give them encouragement that they're seeming to be communicating. It's more interactive that way. But keep your microphones off so that we don't get noise and interruption. Okay, so I'm trying to get the bios of the speakers so that I do a very good job of presenting who they are, and that should help you feel confident that they are knowledgeable in the topic that they are talking about. So I'm gonna pull that up for a second. There's often a lot of communication in preparing this session, so the email thread can be quite long. But give me 1 second to get that. Yeah, and then we can start. So today we have two speakers. We have Dr. Beryl Alu, I think that's the correct way to put it. And Dr. Beryl is already there, and she will put on her camera when she's speaking. She is a medical doctor and holds a master's degree in public health, master's degree of public health in health systems management. And she currently works at Kakamega General Hospital in Western Kenya. And I will also introduce, Dr. Beryl will give us the didactical session, about 20 minutes, and then there will be time for questions and answers. And then after her, Stephen Cartwright will present a case of Ubuntu, and Stephen co-leads Ubuntu Venture, which is within the Arc Venture Studio that is trying to provide a portfolio for wellness and insurance for low and middle income countries. And Stephen has a wealth of experience spanning over 10 years in insurance markets. So we'll hear about that and how we can leverage the products that they offer. But we'll begin with Beryl, who will talk about, in general, not just the case of Ubuntu, but in general, how we can finance healthcare. So I hope you're excited as I am. I think, Beryl, you have your slides, and you can try to project them now before I give you the floor. We do have, as a reminder, we have the chat enabled. Please introduce yourself, tell us about who you are and where you're joining from, and ask questions so that the speakers can respond to them. Let's make the session interactive. Dr. Beryl, have you been able to get your slide?
Enabled my sharing rights. So if you have the slides, you can share on your end.
I'll try to do that, but I also request, I think it is. who can give you the rights. Maybe, are you able to do that?
Yes, I am right away. Okay.
Perfect. Then Dr. Biru can follow the same speed as she likes.
Just a minute. Are you able to share, Dr. Beryl?
Yes.
Good.
Perfect. Okay, so you can proceed, and please put any comments or questions in the chat as Dr. Beru continues. Over to
All
you.
right. Thank you so much. Good afternoon. I am a medical officer working in Kakamega Teaching and Referral Hospital. I also have a degree in health systems and service management from Maseno University. So today's presentation, first of all, I would like to comment, of course, on the situation that is happening in Kenya. And I think it has affected a lot of people, literally all of us. And I condemn very strongly the attack on our medical personnel who are offering emergency services to those who are injured during the strike. And as a medical fraternity, we should never accept such. And I also believe it will affect largely the attendance today, but regardless, we move on. So today's topic is on cancer financing. Another thing I would like to mention, sorry, I'm currently doing a medical camp at CO Port, is close to Uganda. So if we see, if my network drops, probably it would have roamed, and I apologize in advance for that. So this is where I'd like to start. Knowing is not enough. We must apply, and willing is not enough. We must do. So with this quote, there is a lot of work that has been done around cancer. There is a lot of investment that has been done around this field of cancer. But now the implementation, getting the information from the shelves, from the policy, from where it has been stored to the people, this is where the problem is. And this is just an eye-opening presentation. I would like it to be like a discussion, so that we know what we are supposed to do. We know where the challenge is, but now implementation is the problem. So this was the scope of my presentation. We discussed complexity, intensity, and high cost associated with diagnosis, treatment and management, especially advanced stage of cancer. Then we try and look at what has worked, evidence-based interventions that we are able to implement in our setting, in our setting, the African setting, or the low and middle income setting. Interventions that will be able to go to the lowest level to our communities, so that we are able to tackle this challenge. And then we talk about challenges and solutions in healthcare financing and what options are available. So cancer is not new to each and every one of us. And if you look closely, or if we delve deeply, one or two of us have lost someone who has cancer. So it hits home, and it hits very hard. And most or one or all of us have participated in funding or in what are they called, harambes, towards taking care of someone or raising funds for someone who has cancer to get treatment. So it poses a huge economic burden to us, to the world, especially in Africa, where we have resource constraints. So why do we need to talk about this? why do we need to discuss financing cancer in our setting? We have other competing tasks. We have many other issues that we are dealing with. We are looking at infectious diseases. We are looking at our poverty levels. So if we do not talk about funding cancer, at the end of the day, you will find that the economic burden is going to be huge, and each one of us is going to be largely affected. So the high income countries have had considerable milestones, because we say we are 100 years or 200 years behind their independence, or behind their technology. So we are left with tackling this condition. We are left with bearing the burden of this cancer, as we are going to see. So why should we be concerned? Like I said, it's a burden, and it's widely appreciated, and it cuts across all the countries, in the low and middle income countries, largely in Africa. Then we need to establish a capacity for cancer prevention. Prevention is better than cure, and it cannot be overemphasized. And then we need early detection and early diagnosis of cancer, and treatment and as you know, establishing treatment protocols takes time. It might take 5, it might take 10 years for us to see some impact. And then lastly, some of these cancers can be prevented, and the latency period from the cause to the development of the cancer takes several decades. We know the risk factors of cancer. So if we try and prevent, or if we try and tackle these risk factors from an early stage, we will be able to avert many of these conditions. So causes and some of the risk factors, it's going to be a very brief section. We all can sing them loudly in a chorus if we were told to talk about them. And we must understand, the question is, are we holding these causes and risk factors with the weight that they deserve? If we talk about these risk factors, for example, tobacco use, the alcohol use, the smoking, indoor smoking, and other carcinogens, we are able to eliminate this. We are able to have zero exposure from these causes or these risk factors. But what mitigations have we put in place for us to be able to avert this? Then other factors that are not relevant to zero exposure, such as obesity and inactivity. Teamwork. It takes a lot of advocacy in order to insist that obesity is not good for our people. And when we are talking about obesity, we are not body shaming people, because that is the other aspect that brings problem in our society. We must put things into perspective, and we must enlighten the community, or must enlighten our population and tell them, this is obesity. This is not body shaming, and we can do something about it because it's a risk factor, not only in cancer, but other associated non-communicable diseases. Then the cancer control strategies that are available in our countries, in different countries. We can have one sitting as African countries or the world, but we need to tailor make these control strategies, because each country has specific needs. So cancer control, if we are to put in our money, if we are to finance cancer, where should our efforts be directed to? We need to direct our efforts towards prevention. Unfortunately, again, in Africa or low and middle income countries, when we are dealing with cancer financing, I would say we are dealing with majorly 2 problems. One, prevention. And then number 2, majority of our patients come in when it's too late. They come in stage 4, stage 3, stage 4. So we we are caught in between. Should we put our money towards prevention? Should we put our money towards palliative care in order to take care of these patients who are already well advanced in their disease? So prevention, we can use the simplest strategies that are available. Health education, and they're talking about the risk factors so that our population, our communities are able to do what? Are able to participate in taking care of themselves or ourselves. And then early detection, which entails diagnosis and screening. We put emphasis to our healthcare workers, to our national offices and health policymakers, and tell them we need this. We need to invest in cancer diagnosis. It is very expensive. For the patients that I see, by the time you suspect and you make a diagnosis, we usually have lost about an average of 2 months. So we need to talk to our policymakers, and this actually contributed to the fact that we do not have a system of making a diagnosis. We do not have a system of, from the point we suspect, this availability of these diagnostic materials, and then finally linking the patient for treatment. And then we look at the rest of state palliative care. So this is just a snap of what is happening in Kenya, because this is where I come from, and this I adapted it from the National Cancer Institute. So our burden lies in breast and cervical cancer, the top 5: breast, cervical, prostate, and esophageal and colorectal cancer. And if you look at this pie chart, it leans more in terms of gender. Female are mostly affected than male. Is it because we are not making enough diagnosis is it because men do not come to the hospital very early? Is it because we are not catching them at the right time? Is it because of misdiagnosis? I don't know, but it might be a contributing factors, because we know men generally have poor health-seeking behaviors. So if in Kenya we have a lot of guidelines. When I was making this presentation, I was exhausted because we have everything. We have the Vision 2030, we have the Cancer Prevention Act, we have the health policy, the strategic plan, we have the cancer policy, palliative policy, all of it in place. Like, the issue or the biggest challenge now is to take all this information from the paper, from the shelves, and take it to the community. And it involves putting resources together in order to implement what we have been practicing. So we have close to 20 related policies that talk about cancer. When you talk about the non-communicable strategic plan, cancer is one of the top 4 major NCDs that causes death in Kenya. If we talk about the universal health coverage, we talk about prevention, talking cancer at the grassroots. So all these documents, the Tobacco Control Act, we need to implement them in order to reduce the burden of cancer, and with that will reduce the economic burden. It will give us opportunity to direct our minimal resources to where they are largely needed. So these are other still more guidelines that we have on cancer prevention and treatment. So what evidence-based initiatives can we adopt as a region or as low and middle income countries? So there is this concept, Breast Health Global Initiative concept, that is largely inclined, as the name suggests, towards breast. But the principle or what the initiative, how it is packaged, the screening from making diagnosis up to follow-ups of cancer. We can easily emulate it into other types of cancer, and depending also on the needs of your country. So the Global Summit held in 2002 adopted two principles. Two axioms were adopted as principles for guidelines development: that all women have the right to access healthcare. Believe it or not, even up to this point, women have a big barrier when it comes to accessing healthcare. As I'm doing the medical camp today, women have to seek permission from their spouses to come and seek healthcare. Women have to leave their children. They have to put other people first before they come and to seek healthcare. They have to seek permission from so many people. They have so many barriers before they come to get help. And by the time they are coming to seek help, it's usually too late for them. So, and then all women have the right to education about breast cancer. We must talk to our women about, or even men, about prostate cancer, about breast cancer. When our patients have information, they come to the facility early. We do the screening early, which is cost effective, and then we start the treatment early, which will reduce the cost both to the patients and to the healthcare system. And those are the observations that were made. And each country must build programs that fits its unique situation. So the manual, if you look at the manual, it is organized into 4 categories, which can be adopted also for other types of cancer: early detection and access to care, diagnosis and pathology, cancer treatment and allocation of resources, and healthcare systems and public policy. So when it comes to treatment and allocation of resources, cancer is resource intensive. One patient can be seen by a whole system, from the general practitioner to the oncologist to the radiology so you'll find one patient has gone through all the departments when it comes to treatment, has used a lot of resources, even from the diagnostic, from the laboratory, and from the imaging, up to physiotherapy, rehabilitation. So if we do not prevent, if we do not work on prevention, if we do not invest in prevention, we are going to have a lot of problems in future. The other approach that you can use is resource level appropriateness. Now, we assess, we look at what is the current situation. We look at what is the allocation of the resources that we have. Then what are we able to do at the moment, at the grassroots level? We are able, for example, in Kenya now, that a lot of emphasis is being made on achieving universal healthcare through primary health. Our community health promoters, we teach them, we educate them, we talk about the risk factors of cancer. We talk about screening. We emphasize on basic things, on simple screening, coming to the hospital early if you sense something is wrong. So if we start like that and then we build on it, what levels, because we cannot put all these diagnostics in every hospital. We need centers. We need like a referral system where we are able to easily escalate from point A up to the point where our patients are able to access services at the highest level. So when we redistribute these resources these limited resources in such a manner, we are able now to find a way, we are able to manage. Okay, we are able to manage, and we are able to reduce our costs. Good. So basic things that we can be able to do when we're appropriating service. Like I said, we need to look at the monetary cost of the intervention. If you are going to introduce a screening test, at what cost is it to the patients? At what cost is it to the government or the payers? We look at the characteristics of the cancer presenting for treatment. We need, with this, every country has its own unique challenges, and every region has its own distribution, as a unique distribution of the type of cancer, so that we do not take resources where we do not need them, or rather where we will not have a large impact. And then we look at the characteristics of effective interventions and institutional requirements like general infrastructure, availability of health personnel, infection control measures, and specific equipment and drugs that will be needed. So challenges and solutions in healthcare financing, the economic burden of cancer that we've talked about since the beginning of this presentation. And then we need to address socioeconomic disparities. Evaluate pharmaceutical costs. It's always exciting when we come up with new, when we add new products to the market, of course, to the advantage of the patients. But at what cost? Is it at a cost where we are going to leave our patients poor, or their families impoverished, or even the economy? And technological advances. We look at the financial implications of this new technology. And promote research funding. This, we are still lagging behind, not only in Kenya, but I want to believe in the low-income Africa as a whole. We are not funding research. And without research, we will not be able to come up with innovative and ideas that will make impact in our society. Then advocate for equitable access of these resources. If you're a healthcare worker who works whether in a public or a private entity, we must protect all lives. We must protect human life. Where I'm at currently, we have very minimal resources when it comes to screening. And if you screen and you have your impression, the referral, how we refer our patients from this setting, it is very difficult. So the policies, like I said, are there, but now let's implement, let's make noise, let's talk to the right people in order for each and every individual who deserves this treatment to be able to access them. So what cancer control opportunities are there? Prevention, of course, tobacco control. I believe every country has strict measures about tobacco control. Vaccinations, hepatitis B, with the current rise in hepatocellular carcinoma, but I'm happy most countries have hepatitis B in their early childhood immunizations. And also, as healthcare workers, we need to have boosters, or if you work in a hospital setting and you have not get your vaccination, you need to go and get them. Then the human papilloma virus, a life-saving intervention, but also being fought left, right, and center, especially here in Kenya. Let us move away from this. Hepatitis B vaccine has been proven to be effective. It has saved lives, and we need to continue advocating for hepatitis HPV vaccine to be available to all our women and to all our girls.
Dr. Beryl, if you could finalize in about 2 minutes, so that we can.
Yes. Yes, I'm nearly done. So cancer management, diagnosis, and psychological support. We can also put our efforts in this area, as emphasized earlier. Resource level appropriate treatments for curable cancers, such as cervical cancer and breast cancer, and setting up of centers of excellence for treatment of cancers, and then also investing largely in palliative care. So palliative care also suffers setback of resources. And lastly, what do we have? What options do we have in our setting? In my country, I am still looking, because the budgetary allocation to health currently still stands at 6% versus the Abuja Declaration commitment of 15%. So this is a big setback. We might not be able to do much if this trend continues. The social health insurance, we need to come up with packages that includes the screening or making diagnosis of our patient cancer, and then inclusion of private insurance. How are they able to help or to boost the social health in order to spread the risk? And public-private partnerships. Which those are my references. Thank you so much for your time.
Thank you so much, Dr. Alu. Very, very comprehensive guide on how to approach financing. I think if I was in cancer control, and you've given, I think, more to the side of prevention, and I have seen, for example, WHO has mentioned that for every dollar invested in screening, let's say for cervical cancer, you get about $3.6 return on investment, which I think is quite a profitable business if this was really to just be a business. But that figure goes up to $26 for every dollar you invest, if you consider the lifetime cost, if you consider all the things that you prevent, all the return that you get, for example, patients not getting out of work, and women being able to take care of their kids so that they can go to school. If you do that entire math, it turns out to be a hugely profitable business if you do invest in cancer control, for example, screening for cervical cancer. So thank you so much. I hope others have had time to reflect. There was a question in the chat, but in the interest of time, I will ask the next speaker, and maybe Dr. Alu can respond to the question. And please, if you have other questions, put them in the chat. Dr. Alu is hanging around and she can comment on them. But one of the things that she mentioned was how to get insurance, how to get private-public partnerships. And with us, we have Stephen, who comes from Ubuntu, and is going to talk about one of the products, or a portfolio of products that they offer in terms of providing health financing, where we don't have enough public financing for cancer control. So, Stephen, I see your presentation is on. If you could also try to take us through quickly in about 15 minutes, and then we'll have time to have a nice Q&A. Thank you so much. Over to you. You're muted still, so if you could unmute, then we won't have to read your lips. Yes.
Hi, can you see the full screen? I can't see what I'm sharing, so.
No, so you need to maybe press F5 or something.
Oh, there we go.
Yeah, perfect.
Does that work? Okay. Thank you everyone for the opportunity to just share what Ubuntu is trying to accomplish in the very early stages of this venture. But Ubuntu has been set up really to offer peace of mind to probably the middle income segment of emerging market communities by combining wellness with insurance to give access to affordable healthcare. So Ubuntu is part of a venture studio called the ARC Venture Studio. This was established in 2023 to, as I said, to deliver affordable wellness services and access to treatment for those in the emerging middle income segments. This venture is supported by some pharmaceutical partners like Roche, MSD and Pfizer, as well as some insurance companies with Swiss Re and Daiichi, who have helped us out, along with the Gates Foundation when we started this venture. We also work with local insurers and health partnerships to deliver the solution in market. And we're currently working with Avenue Health Clinics and APA Insurance in the local market in Kenya, which is the first market where we wanted to trial this proposition. So moving quickly on, the journey that we see for people in many communities, especially in emerging markets, is that there's a massive challenge with people being excluded from healthcare systems. What we see is that the penetration of private medical insurance is pretty slim, you know, and it's the top 5% of people, maybe in large corporations or international companies, things like that, maybe, you know, the senior members of a business who actually have that private medical insurance. And then we've got the very low income, who are more often supported by universal healthcare, and quite often, and I think Beryl alluded to this within her presentation, sometimes is not as efficient as the governments want it to be, and also a lot of the funding isn't there to deliver either the quality or the availability and the accessibility of the treatments that are required. We know that, you know, we can't solve all the problems with our solutions. So what we're trying to do is to address a specific segment of the community. So we wanted to develop a solution that was affordable, and that would combine wellness and insurance in a package. And the first area that we wanted to look at, so the initial focus was on women's health, and specifically, specifically female cancers. I think it's fairly kind of well known amongst this community that the top two female cancers are breast and cervical cancers, both in terms of incidence and also mortality rates. The existing benefit limits, either from universal healthcare through NHIF in Kenya specifically, where we're focused at the moment, doesn't necessarily give the treatments that people want. And even when they have private medical care, those that are fortunate to have private medical care, which could cost anywhere between, I don't know, $500 and $1,000 a year, actually has limits on the amount of critical care insurance payments. So we know that the existing benefit limits are not sufficient to cover the right care. The other point that Dr. Alou mentioned is that the challenge of early screening and vaccinations are really, really low. And this really leads to high mortality, principally because the stats show that in Kenya specifically, and this is replicated amongst other African countries and also some of the Asian countries as well, is that 80% of women, especially for breast and cervical cancer, are diagnosed at stage 3 and stage 4. So what we wanted to do was to change that dynamic. The reason that we chose Kenya as our first market is that a number of the people within the Ubuntu venture had deep relationships with some partnerships in Kenya. So this is why we chose Kenya to the first market, because we wanted to take a product to market quickly and actually go from design to launch within 12 months, which is what we did. Working with local partners, APA Insurance being one, Ask Nivi, which is a technology platform to deliver the chatbot, and also we're initially going to market with Avenue Healthcare, who are a phenomenal partner to go to market with. Our ambitions are broader than that. So once we test the product in the market, we prove the price points and the customer demand, so what we call market fit. We have aspirations to go global with this, but it's really focused in emerging markets, so expansion into other African countries and also some of the Asian markets as well. So moving quickly on, I mentioned about this kind of missing middle, and we can't solve all the problems, but what we felt was that there's a lot of mid-income people within Africa, but specifically within Kenya, that can afford something. They may not be able to afford a full PMI insurance, but they can afford something which gives them something more than maybe the universal healthcare through NHIF. And we wanted to try and find something that was affordable, but it wasn't just insurance, because no one wants to buy insurance. It's a really, really challenging concept. Insurance companies are generally not trusted. They generally don't pay out. There is a cultural and education challenge that we need to overcome, which is if you get insurance, you're probably thinking either I don't want to buy insurance because it's going to make something happen. So I'm kind of like, yeah, I don't know what the word is, but I'm doing something that it's more likely now I've got insurance that something's going to happen to me. But there's also the cultural element that I'm buying insurance and I don't get anything in return, unless I'm one of those 1 in 1,000 people that get in this case diagnosed with cancer. So what we wanted to do was to wrap around some really, really valuable prevention services and some health and education services, which would enable people to get immediate value from the product. And then if they are unfortunate enough to be diagnosed with cancer, there's also a cash payment that will enable them not only to get the best possible treatment, but also to help them with out-of-pocket expenses, which we know is a significant issue for women and families, to take time out of work, to get the kids looked after, whatever it is, you know, for accommodation and travel to some of these facilities is really important to have both the cash element to enable treatment, but also to help out with some of these out-of-pocket expenses. So that's what we've designed. In terms of the prevention services, we want to offer wellness, which is things like kind of an annual health checkup, which is blood pressure, body mass, blood sugar, kind of all of these things that would enable kind of better health outcomes, but also specifically for breast and cervical cancer, we have a clinical breast exam. Currently, we have a pap smear test. We're also looking to work with Roche to deliver HPV DNA tests. And we're looking at the potential of that and the kind of pros and cons versus the pap smear, but also we're offering an HPV vaccination as part of this. If you add up all of these costs in association with the wellness services, the screening services, and specifically the HPV vaccination for cervical cancer, the cost of the product is much, much lower than the aggregate benefit that each of the potential customers can avail themselves of. So moving forward very quickly to the customer journey on the health services. At the moment, we're working with Avenue Healthcare. The customer can, once they've purchased the product, they can book their appointments either through a phone call, or we actually prefer them to book it through the chatbot. It's an automatic appointment system. They can go on the chatbot, which is on WhatsApp. They can look at the availability of the appointments and book their appointments. They then go and present their virtual ID card when they turn up for the appointment, and then they get all of those cashless process. So that's what we're offering in terms of the health services. The dynamic that we want to change really is we want to change the dynamic of 80% of people being diagnosed at stage 3 and 4, and we want to change that dynamic to 80% of people being diagnosed at stage 1 and 2, where we know that the survival rate and the treatments are there, and the survival rates are significant. They're in, you know, especially at stage 1, they're in the 80 to 90% on breast cancer and cervical cancer. In addition, we want to increase the rates of vaccinations, which we know, I live in the UK, and cervical cancer hasn't necessarily been eradicated, but it's on the pathway to being eradicated through the government schemes of vaccinating not only just girls, but also boys in the government programs. So even though this is really aimed at the female customers, we believe that we really want to get these women vaccinated through this program. In addition to that, we want to provide health education and awareness, and we kind of do that through a health chatbot with our partnership with NIVI. So NIVI are an organisation that have deep experience in delivering health awareness and calls to action through their chatbot, and with them to engage our customers on a weekly basis. So when a customer signs up, they're onboarded, they can book their screenings, they can book their vaccinations, they get health and wellness tips through kind of quizzes and things like that. There's awareness about, what do I expect when I go for a screening? What's a pap smear like? What can I expect? You know, facts about vaccines to try to reduce the misinformation around vaccines. There's all of this information within a chatbot, and currently our engagement levels kind of range between 25 and 50% on a regular basis of the customers looking at and engaging with some of the chatbot information that we're delivering. So if I then move to the protection solution, so we've gone through the kind of prevention services, we're now looking at the protection solution, which is effectively the insurance. So in the case of a positive diagnosis for breast, cervical or ovarian cancer, cash benefits are paid out, as I said earlier, to cover both for treatment and also related out-of-pocket expenses. Now, when someone is also diagnosed with cancer, we also have a patient navigation service that kicks in. This is a one-to-one navigation service that offers support and guidance to that member throughout that process. We know that being diagnosed with cancer is a very alarming time. It's not necessarily great on the mental health either of the patient or their family. So these navigation services are really to help that individual walk through the various processes. I think Dr. Alou mentioned the number of health professionals that get involved with someone's treatment and the treatment protocols. And we really strongly believe that these patient navigation services by clinical professionals can actually help the patient through this process. So just looking very specifically at the protection solution, I've put some dollar values at the bottom here for those that are not necessarily familiar with the exchange rate in your own currencies. But dollars, you can get up to $25,000 worth of insurance benefits. And similarly, we have kind of a silver, a gold, and a platinum level where you can avail yourselves of some higher values. Now, when we look at private medical schemes, even the kind of ones that cost maybe $1,000, some of those limits are only kind of $3,000 or $4,000. So we really believe that this product is exceptional value, not only because of the prevention services and the wellness services, but also because of the cash payments that can actually treat with some of the innovative treatments that are out there and actually give a much higher chance of full recovery or really good treatment through that process. The way that we've designed it is also to reduce the cost of the insurance product. So the way that we designed it is that people can get their cash payments on stage of cancer. So we've had a look at the cost per stage of cancer. So at stage 1 diagnosis, the treatments are a lot less expensive. So we have that kind of cash payment there. And then at various other stages, if a patient moves through those stages, they also get that additional cash payment. So that's the way that we've designed it with APA. to try and get the lowest possible cost. The APA product is out there. Even though the venture is called Ubuntu, we have a brand in market with APA, and it's called APA Femina Plus. And those in Nairobi may have seen these very, very large billboards out there to really drive awareness and create lead generation to get people to come through and actually purchase the product. We're using various channels. We have retail sales, so people, kind of individuals buying the product. We have small businesses purchasing the product for their employees, so on behalf of their employees. We also have banks who are selling the product to their banking customers, especially to female customers who have kind of specific female products through their banks. So we're looking with APA to look through their various distribution partnerships, through insurance brokers, through corporate clients, through SMEs, through their retail channels, to get as broader reach as we possibly can. And we're always looking for further partnerships and distribution channels to get the product out there. So finally, our future vision isn't necessarily just on Kenya, and it's not just on female cancers. What we want to do is to have a portfolio of products within the Ubuntu platform that allows people at whatever stage they are to purchase the products that are right for them at that particular time. So cancer is a key focus. We have a women's cancer product in market. We're looking potentially to design a male cancer product that could be prostate cancer, it could be colorectal cancer, something like that, that could be specifically for men. And we also want to look at other non-communicable diseases. We also like looking at potentially malaria, dengue, some of those kind of products. So we want a broader portfolio, but not just in Kenya. We want to expand this out. So that's a very kind of rushed presentation. Happy to take any questions from you, but we're really excited to have the product launched. It took from design phase to launch around about 12 months, working with some phenomenal partners in Kenya, which are APA Insurance, with Avenue Healthcare, with AskNivi, the technology platform. But not only that, you know, our pharmaceutical partners have been really, really helpful, guiding us, providing the best possible kind of content from a clinical side for our chatbots. We're also working with CCAN and also Kenko, really to try and drive the awareness of the product out there. So I will stop now, and if you have any questions, more than happy to answer them. Thank you.
Thank you, Stephen. Very nice presentation as well. And I think there's a lot of interest in now you can look at the chat and see the questions. But thanks. I think this is the most interesting part of the discussion, actually, where, you know, at first you prepare a presentation thinking this is what people would want to know. But when you present and people have specific questions, that I think is the most engaging. So I ask everyone to, you can turn on your video, you can type in the chat, or you can raise your hand and ask questions directly to Dr. Beryl Alu, who is still there, but also Stephen, who has just finished presenting. For now, there's been some direct questions that I think are coming to you, Stephen, and I'll read them out. One is from Victor Modi, and they are asking, what are the financial limits or caps on cancer-related expenses that your policies cover in Kenya? Or does it depend on the hospital or partner? I assume you understand what this question is about in terms of the limits or the caps, so you could quickly directly answer that.
Yeah, sure. So, so within the product policy, the premium that a customer pays for covers both the wellness services, the screenings, and the insurance payout. So all of the screenings and the vaccinations are included within that. And whatever level that you have, silver, gold, or platinum, all of those services are included. In terms of the payment, this is a cash payment. So depending on the stage of diagnosis that that patient has with either breast, cervical, or ovarian cancer, they get that specific cash payment for that specific stage. So for the stage 3 diagnosis, for the platinum level, it would be 2.5 million shillings. Now, for that 2.5 million shillings, we would expect that individual to focus that cash payment on treatment. Now, if that individual, and I'll kind of answer the second question. So if that individual wants to use the NHIF for some of their treatment, that's fine. They can use the NHIF for some of the treatment. This is a cash payment to them that they can use for whatever. Now, I know this doesn't sound great, but the reality is that a number of people that we're aware of that don't actually get their treatment in Kenya. A lot of people go to India to get their treatment for various reasons, one of which is cost, which is crazy to me, and the other one is quality of healthcare. Now, I don't necessarily believe that, because I think the quality of healthcare in Kenya is exceptionally high from what I've seen so far. But it is up to the individual as to what they want to do, and this cash payment can also cover treatment in India or whatever other country that individual wants to go to. So in answer to the question, the caps are the limits for that specific band of cover, gold, silver, or platinum, and also the stage of diagnosis. Now, if someone gets stage 1, moves to stage 2, 3, and 4, they get the full payment cash amount. If someone has another APA medical policy, then this is in addition to it. This isn't a reimbursement model that a lot of the insurance products have. This is a cash payment. So if you have, like a lot of people that we're selling to at the moment, actually already have some form of a private medical insurance. So a lot of the APA employees have actually taken up this product, knowing that they've got an APA private medical insurance scheme, because there are limits on the amount of critical care and cancer care cover that they have. And they feel that this product, in addition to that, is actually really, really valuable. So I'm not sure whether that answers all the questions.
Yeah, I think you also talked about what happens if someone already has another. And yeah, I've seen that sometimes you go to the insurance and they say, oh, no, we don't cover that, or you've exceeded the limits, and sometimes people have to take out insurance from multiple insurers so that they can combine. So I think that covers the question. Please put more questions in the chat or comments, or even share your own experience of other innovative approaches. There was a question earlier on that was quite general, again from Victor, who was asking how can we advocate for streamlined and timely access to cancer treatment in Kenya, I guess also for Uganda, where I come from, where patients face delays of up to a month, and I think Dr. Beryl talked about this, for getting treatment, chemotherapy, and sometimes people default. I think this is quite general comment, but if I can give you 1 minute each to say how, for example, Dr. Beryl, how this can be done, and also for you, Stephen, how your product can contribute to this in brief before we get other questions. So let's make it quick, and if we can even finish early, that would be good, but it would be good to have all the questions answered. So starting with you, Dr. Beryl Alu, can you say how can we advocate?
Thank you for the question. First, we look at the, what are they called? Policies that are available. We have everything already laid out. So advocacy does not necessarily have a specific means or a specific way of doing it. You as a healthcare worker, wherever you are, you will be the advocate of the patient. No, every single day, no matter what happens. So if you are doing the right thing through the laid or the outlaid guidelines, and you strongly believe that whatever it is that you're advocating for or you're asking for is the right thing, that is advocacy. Remember that these resources are limited. So if you do not fight for it as a healthcare worker, those resources are going to, or if you do not show the need that these problems are, and this is through documentation and data collection, these resources are going to be reallocated into other sectors. So there is no one size or one shoe fits all size when it comes to advocacy.
Thank you. Stephen, you have a comment on this? Maybe from your side, should we just be more aggressive in marketing? Should we protest? How do we make a law that forces people to take out insurance? What are your thoughts?
Yeah, I think cancer care. I mean, I can only really speak to Kenya because that's the market that I'm currently working in. But I think there are some similarities across many of the countries that are represented here. The whole cancer journey is really challenging, from education, from the fear of the word cancer, and I think some of that really needs to be addressed, because people think the word cancer means automatic death, which it doesn't really. That's a complete misnomer, because there are some great treatments out there. Screening can prevent that, and I think where we're looking at changing the dynamic, it's really about education and screening. If you can change that dynamic within any country, you're then reducing the challenges of the resources and the delays that come with people who are getting to hospital at stage 4 the immediate treatment. I know, having spoken to people at the NCI in Kenya and Kenko and CCAN. I mean, there's so many organizations that really want to change the dynamic, and I really see a groundswell of momentum here to really change the dynamic, not only in Kenya, but also in some of the other countries. And there's some great work being done, especially by CCAN, to understand some of the challenges and the gaps, either with resources or facilities, or, some of the areas of bottlenecks that can actually be there just through bureaucracy or things like that.
Mm.
So there are so many organizations doing a fantastic job to try to streamline some of the processes to try and resolve some of these challenges and bottlenecks. I don't think any of us have the answers to all of it, but what it does mean is that each of us as individuals have a really key path to play in resolving some of these in whatever expertise area that we have.
Yeah.
Insurance is one of the one of the solutions, but again, we're only tackling a very small segment of that mid-income kind of population that can afford something like this, and it doesn't resolve all the problems.
Yeah. Thank you. So again, in the interest of time, I'm trying to rush through. I have a few questions that I wrote down myself that are very specific, and I assume that they're relevant to others. So going back to this issue of, our relationship with insurance, which tends to, you feel like if I put in my money, I am just making the insurance companies rich, especially because sometimes it is sometimes even a legal battle to get them to pay. We see this with motor insurance, so we have not very good experience. Insurance basically benefits on not paying. That's how they make more money. So how do we then incentivize? And here I see, for example, that with Ubuntu, you also provide other services. So for example, health education via the chatbot or navigation services, so that a person already feels like, even if I don't get the other cash out payment because I didn't get the cancer, it was worth it. So the question that I have for you is, do you see that clients appreciate that? Do they feel like this is worth that $4 or $5 or $10 to interact with a chatbot, or to find it easy to navigate when they need to go for screening? Because then they will feel like they can pay for it, even if they don't eventually become unfortunate enough to get the cancer. So how do we make it that people are happy to pay even though they might not get the ultimate assistance that they need? Do you see that? People appreciate that? And then do we communicate this experiences with others.
I
So from
think
your experience, Stephen, how does that look like?
Yeah, so we're still in very early stages of gathering a lot of the data from our customers. We're seeing probably slightly higher screening rates than probably kind of experience with the general population, because we're using that education through the chatbot to educate people that screening is a really good thing to do. Try and demystify some of the things about screening, really encouraging people. And we're using kind of various behaviors. So we've actually changed the way, for example, so when someone is onboarded, we're actually automatically booking them an appointment.
Right.
And it's up to them to say, no, I don't want an appointment, or they turn up. Because when we started out, we were letting people make the appointments themselves, and we were seeing a much lower kind of rate of screening. So through some of the behavioral data that we're seeing, we can change the engagement patterns to try and get the outcomes that we want. I think having worked, my background is in microinsurance, mainly on life and health products, and generally, when people buy something, the dollar that they're buying it with is competing with so many other things. And would they prefer to spend $1 on something they can get some immediate benefit from? Or would they prefer to spend $1 on something else that may or may not be coming back to them at a certain point in time? So we really wanted to emphasize the wellness rather than having it as an insurance product with wellness. This is a wellness product with insurance. There are insurance products out there, there are wellness products out there, but no one's really kind of combined them together to date. This is an experiment, this is a venture, this is something that we're trying to see has value in the market. All the feedback that we're getting is that this is a really valuable product. It's really good. The emphasis on wellness is really good. What we want to give is peace of mind. We want to give people peace of mind that when they get vaccinated, their chance of cervical cancer is dramatically reduced. When they get screened, they have peace of mind that there's nothing wrong with them. And as they get screened on the protocols every 3 years or whatever it is, then they have that continued peace of mind. So there's always value in the product.
Thanks. So I guess this is also something to do with getting strategies, implementation strategies on how do we get something that we know works. As you said, sometimes people have already been paid for insurance, but they still don't come unless you maybe proactively book them for the appointments. So that shows you that it's not enough knowing, it's also that you have to actively use the knowledge and find out the strategies that work. So sometimes you have to push, sometimes you have to educate and people make decisions. Sometimes there's a bit of a nudging that is needed. And I think that's one of the things that Dr. Alou started with by saying that there is a gap between what we know. There's also policies. It's a different thing when it comes to implementation. So I think this is important to collect data, and I'm really looking forward to seeing what you learn and how we can apply these insights. What makes people want to insure? Is it that they care about the wellness? And what works for this kind of patients versus these kind of patients? People who are salaried employees, versus people who earn every day, and people of this age group, and all those kinds of things. So this is interesting to see. I had another question. I don't know if these people have questions online before I take over all the time. So please, you can raise your hand. If you don't have questions, I still have a few. We have about 10 minutes to the end of the session. I don't see it raised.
Have you seen,
just
John
comment?
Black, there's a question there from Maggie Kage.
Oh yeah, Maggie asked, I think she dropped off when Stephen was answering this question. So he says, what of people with other medical insurance? And Stephen said in brief that this becomes an additional, so it's top up to what they already have. So it's extra. So if you already use your APA or whichever other insurance to pay for the medical services, then you can use whatever you get from Ubuntu to let's say, cover for, I don't know, transport costs or something. I think that was the answer.
Yeah, so it doesn't need to be associated with another APA product either. So you could have a product from Jubilee or kind of Britam or whoever, and this is or it can be purchased independently as just a cancer product. I think just the other thing to say is that we're also looking potentially, we haven't done it yet, but we can potentially to roll out the chatbot to the general public in Kenya.
That would be quite interesting. Maybe even get more clients. Yeah.
Yeah. So this would be really to disseminate good information about cancer, female cancer, general wellness, and things like that. So that's a proposal that we're looking at. I can't confirm that we're going to be doing it, but it's something that we're hoping to do. And if we do it, then Kenco is actually going to be one of the key partners in that, providing a lot of the content and things like that. So, this is something on our roadmap that we want to do as well.
Yeah, thank you. I want either of you can comment on this. There's a general trend, and I've seen this in Uganda, but maybe also in Kenya, I assume, where telecoms that have been running mobile money are encouraging people to save. And they do these micro savings, maybe 500 shillings. Well, that's a lot of money for Kenyan shillings. Let's say 50 shillings a week or a month, but micro savings that they then use to even give you some bit of interest at the end of the month. And now they're also using these kind of products for health insurance. How is that? How does that relate to the products that you offer, and how do we get people to use these? I know that many times they cover a very small fee, like transportation cost, but how is that working? Is that a thing that you think we can, for example, healthcare providers tell our patients to take on if they think, oh, this APA is quite expensive and is for the rich, and I just need something that can help me? Could you comment on these initiatives? Because we're looking for innovative ways of getting everyone insured, and a little bit helps. Yeah.
Yeah. So I think there are already initiatives in there within within the sector, both in terms of the health sector and the technology to do it. There's a product called MTIBA that is out there that people can effectively use as a savings wallet that can then be used for health treatments or pharmacy kind of drugs and things like that. So there are solutions out there already that can help people save for future events, but that is kind of ring fence. That money is ring fence for specific use on healthcare provision. So there are things around there. We need to look at affordability. One of the challenges, especially with insurance, and it's kind of one of the vagaries of insurance and insurers and underwriters and things, is that they want to have the money up front. Generally, there can be monthly payment installments kind of coming forward, but I think my experience through the micro sector is that there are people who would be able to save 1 month, but not the next.
Right.
Not the next. So their income is kind of very spiky, and that's a challenge with some of the products like this. And we need to be more innovative to deliver better ways that people can spread those payments over a period of time that can still give them coverage. I think the other challenge is that, especially with cancer care, you could potentially have a product that could just cover out-of-pocket expenses, for example, but wouldn't cover any of the treatment. But that's not really what we wanted to do at the time. We wanted to have something that would provide significant cash payments for treatment. But it's all about affordability, really, because it does come at a cost, unfortunately.
Yeah, indeed. Thank you so much. We are at the end of the discussion. I see there's maybe one last question from Victor, who is asking how quickly are claims typically processed, especially for cancer treatment that may require immediate attention. If you could say in one sentence so that we can conclude for you, Victor, rather for you, Stephen, I think this comes to you. Time processing.
Yeah, my understanding is that it's very rapid. It's probably, I think I would need to look at the policy details from APA, but it's pretty rapid. I mean, it's within a month,
All right.
based on the various kind of clarifications of the diagnosis. But yeah, it's pretty quick.
Yeah. Okay, so I want us to conclude. I don't see any more questions. I think this is quite an interesting discussion. Stephen is going to leave his contact for those of you who are interested in getting this product. So this is an advert for you, Stephen. But there's, of course, many other initiatives that can be used. He mentioned MTIBA. There's lots of private insurance. I think in Kenya, there's also been NHIF. And many other offerings. And of course, we don't have only Kenyans, we have other people from other countries who are joining. I think for us as healthcare providers, it is our duty to tell people about these issues, tell people about insurance and show them the value. And if better advise our patients, we can advocate for